Hi, class. I wanted to go ahead and continue and finish up the CKD presentation, or this would be part two. I think I'm feeling a little better today, so I feel like I can actually finish this presentation. And so, just in case before things turn around, let me go ahead and get started now. I tend to sometimes get a little tired sooner, but we'll see how it goes. So let me go ahead and start sharing my desktop with you. All right, I think I got that working. All right. All right, so let me present. So right now, we want to have a more in-depth discussion with you about the actual management of those different priority issues that these patients typically have. So in the first one, we're talking about managing fluid volume. And of course, we do a lot of this by weighing these patients daily, monitoring their intake and output. We have to think about fluid restrictions and such as that. And of course, dialysis sometimes is another way that we actually manage volume. I need you to always be on the lookout for fluid volume overload. And what you'll see in these patients is that the urine output is going to be significantly diminished. They will have low oxygen saturation levels. They might also have adventitious breath sounds because of all that fluid that is backing up into the lungs. And so that fluid has to go somewhere. And just like with CHF and how the left ventricle can push blood forward and it goes back into the lungs. Same thing happens with fluid overload. These patients, although it may not necessarily be cardiac cause, but the fluid being in the cardiovascular system itself will cause the fluids to back up into the cardiovascular system. Now, there are some expected outcomes that we are looking for in these patients. We want them to have a normal blood pressure. We also want them to have a normal CVP or central venous pressure. And remember, this is the CVP line, and the range is 2 to 6. And so with fluid overload, you can expect the CVP to be greater than 6. All right, and excuse me. And of course, the CVP determines the body fluid status. By the way, just as a reminder, we also want to have normal, close to normal electrolytes. We want a more stable body weight, particularly in between hemodialysis. I feel like I somehow went through this information already, and let me see if I do have a duplication of this information. For some reason, it just seems duplicate. It may not be, I mean, and then some of it is a bit of overlap. Yeah, some of it can be a bit of overlap. So that's number 16. Maybe I just kind of read through it and felt like I actually um, lectured on it. So forgive me, my mind is kind of like, all over the place. Um, so we want to look at body weight stability, especially in between dialysis. Dialysis either sometimes pull off fluids. It might give more. It may give fluids, but what you're trying to do is basically maintain a stable body weight, which is the key here. Now, patients with CKD require multiple modalities such as drug treatment, nutritional therapy, fluid restrictions, as I mentioned, and also hemodialysis once they reach stage 5. All right, because then they're not putting out any urine output whatsoever at that point. All right. Now, hemodialysis involves intermittent treatment for 3 to 4 hours each time, and 3 times a week. That is what the therapy usually involves. These patients, they also have peritoneal dialysis, and this is when we're using the peritoneum of the patient's abdominal cavity as the dialyzing membrane. And so we take dialysate and infuse this dialysate solution through the peritoneum. Well, it goes through a catheter, a peritoneal dialysis catheter. This device is actually tunneled into the peritoneum, and it is that dialysate fluid that is actually used to either or it has a certain concentration of glucose or dialysate, if you will. It actually pulls fluids out of the off of the patient's body, so to speak, but it uses that peritoneum of the patient in order to do that. And I'll hopefully be able to show you some pictures here shortly of what that looks like. But the dialysate solution is a large bag of solution, and we should be able to get a little more into that later. All right. Now, for fluid management, we want to monitor again the intake and output. We're assessing hydration status. There are ways to do that, of course. You're looking at the skin turgor, and then of course you're assessing the skin for moisture versus very dry and what have you. We also want to observe for signs and symptoms of fluid overload, like distended neck veins, lung crackles, etc. Signs that things are backing up, if you will. Now, Lasix is used to increase urine output for those with mild to severe CKD. It helps to increase the urine output in order to decrease fluid overload, and also to decrease the blood pressure. And it is only good for those patients who still have the ability to urinate. Now, diuretics are not given to patients who are started on hemodialysis um, with reduced renal function. And this is due to the fact that the drug itself can build up in the patient's body to dangerous toxic levels. So you only, in other words, you're only giving diuretics to patients who still have the ability to urinate. Other management activities for fluid overload. Um, Again, daily weights, intake and output, monitor the patient before and after dialysis is also important. We also want to observe fluid restrictions of the type of fluids or intake. For example, as far as oral, we want to rather measure oral, IV, enteral, what we're feeding them through the gut, and so forth. Um, Now, while on fluid restriction, um, we usually have like a 24-hour we have like a certain cc's that we're trying to restrict with these patients, and so we typically spread it out over a 24-hour period. So we spread out over a 24-hour period. In other words, we give more fluids during the day versus at nighttime. Because during the daytime is when people are alert and awake, and they're aware of what is going on, and they're more aware that they're thirsty and that they want to quench that thirst. And so we tend to give these patients more fluids during the daytime, because at nighttime, especially if you are one of those patients who sleep through the night, then you're not as aware that your fluid restriction um, has been restricted. All right. Um, Now, of course, we want to prevent pulmonary edema, and so the patient will have no respiratory difficulty or adventitious breath sounds. We want to maintain O2 saturation at least greater than 92%. Pulmonary edema. Um, Now, pulmonary edema occur typically from heart failure related to fluid overload, or from blood vessel injury. Um, all right. Now, pulmonary edema occurs as blood volume cannot be ejected from the left ventricle. And of course, this volume backs up into the pulmonary vasculature and leaks through the alveolar capillary membrane and into the lungs, which leads to edema of the lung tissue. Now, PE can also occur when uremia injures, that poison that the kidneys can no longer excrete. Well, that uremia, that poison, it can also build up in the bloodstream, and then it causes damage to the lungs, blood vasculature. This leads to inflammation. This is the effect this poison has on the lungs vascular tissue. And so it will lead to inflammation. And of course, the inflammation will cause that capillary leak. Um, and the fluids leak into the pulmonary circulation and into the lung tissue or alveoli. It can also leak into the pleural space, which can lead to what we call a pleural effusion. All a part of that inflammatory process related to that the toxic buildup. Now, signs and symptoms of pulmonary edema, as far as early indicators, we want to look for restlessness, anxiety, increased heart rate, shortness of breath, crackles, especially crackles in the basis of the lungs. As the pulmonary edema progresses, You can look for complications such as pink frothy sputum, diaphoresis, and cyanosis. And this is certainly a medical emergency, and these patients are getting ready to die if you don't get them out of this. Now, of course, depending on what stage or what stage of kidney renal disease a patient is in, if they're in a stage where they still can produce a lot of urine, as long as you're giving them adequate diuretics, then diuretics will likely be the choice, drug of choice, treatment of choice, if you will. But then, of course, if you have those patients who are in stage 5 and they're not putting out much in the way of urine at all, and of course, Lasix will not be of any use, and therefore, a dialysis might very well be, or in all likelihood, would be the therapy of choice in that respect. Now, treatment does include acute hospitalization, of course, oxygen, because they don't have good oxygen gas exchange. These patients should also be placed in a high Fowler's position in order to help facilitate breathing. Loop diuretics is also given. Remember, loop diuretics are your powerful diuretics. You have about like 3 main powerful loop diuretics that works on the loop of Henle and the distal tubules. But you have furosemide or Lasix, you have your torsemide and Bumex as well. And don't ever forget those loop diuretics, are very important. And so, of course, this is what causes patients to lose a lot of potassium and magnesium and calcium and so forth. But this is the drug that is used to treat pulmonary edema, especially in the context of those patients who are still producing a fair amount of urine. Now, we must be careful with administering IV Lasix or furosemide when given to patients with decreased kidney function. It can lead to ototoxicity or ear damage with hearing loss. All right, that's the toxicity that is building up because you cannot excrete the metabolites, from Lasix. We want to monitor the vital signs, reassess breath sounds. Patients must be weighed as ordered while on Lasix in order to monitor the therapy. There's also IV morphine. Sulfate is given in order to decrease myocardial oxygen demand. And this is done by causing vasodilation of the blood vessels. And so, of course, we want to monitor the patient's respiratory rate while they're on morphine and watch for any kind of respiratory depression because that's what morphine can do. And also monitor the patient's vital signs, especially their blood pressure, because it does, if the vasculature is dilated, then your blood pressure can also sometimes drop too low. Now, nitroglycerin IV is given to decrease the pulmonary pressure from left heart failure by dilating the blood vessels. So when you think about it now, I want you to think about this. Think about that combination of IV morphine, IV Lasix, and nitroglycerin, and how it can cause severe hypotension. All these drugs in combination can significantly drop the blood pressure, causing severe hypotension. All right. And then now you have even more decreased perfusion to the kidneys, so that pre-renal injury can occur. We want to also observe electrolytes during loop diuretic treatment, as this type of treatment from diuretics can deplete them. So we monitor the ECG for dysrhythmias. Now, when the respiratory system worsens, these are signs and symptoms that are concerning. These patients will develop increased hypoxemia, meaning their O2 or SpO2 levels are going to be decreased. These patients will become restless. There's also decreased cognition or new onset confusion. And if respiratory failure ensues, of course, these patients are going to require intubation and ventilation as well. As far as increasing cardiac function, the normal outcomes here that we are expecting, we expect a normal blood pressure. We also expect a normal ejection fraction, normal peripheral pulses, and as well as normal cognition with these patients. Now we have to manage the blood pressure because hypertension does result in increased damage to the renals or kidneys. We control blood pressure with medications such as diuretics. For example, a thiazide diuretic or HCTZ. Here we don't typically want to use the Lasix because it's too powerful, and so we want a more light diuretic to help diurese these patients a bit to lower the blood pressure. We also prescribe these patients with calcium channel blockers. That dilates blood vessels, causing the left ventricle to work less. The ACE inhibitor, of course, which decreases the amount of sodium in water retention, actually causes sodium water excretion. And also it dilates the arterial vascular system, ACE inhibitors do. Then you have your alpha adrenergic blockers, your beta adrenergic blockers, which of course can decrease the heart rate, decrease the blood pressure, and then also there's the vasodilators that we prescribe that are prescribed for these patients as well. Now, ACE is the best drug to use in order to decrease any cardiovascular event, especially with patients, and I want you to hear this very good, especially with those patients with CKD and hypertension. ACE inhibitors is one of the best drugs to prescribe for those types of patients. You should never miss that. Calcium channel blockers improves the glomerular filtration rate, and it increases blood flow to the kidneys. All right, so now the goal for blood pressure for these patients with CKD is roughly about 135/85. We also want to teach or monitor the blood pressure daily. Have our patients to keep a record and to recheck it for accuracy. We also teach them that there's a relationship between the blood pressure control, diet, and drug therapy. So there's a relationship between good blood pressure control, diet, and drug therapy. They all work hand in hand. All right, and as far as enhancing nutrition, the expected outcome for CKD patients, these patients should be on a protein caloric intake that is appropriate to their weight to height ratio. They must have good muscle tone, of course, because you are going to have to likely limit some of the protein. So we always want to monitor their muscle tone. We know that proteins do help build a muscle, but in these types of patients, we will have to likely do some reductions of protein in the diet. And so muscular tone assessment. Lab values, we want to look at the serum albumin levels because, again, we are reducing the protein. And also their hemoglobin and hematocrit. All these tests can tell us what's going on with them nutrition-wise. Now, dietary needs include control of protein intake, fluid intake limitations. A dietitian may also assist with this. We have to restrict the amount of potassium and sodium and phosphorus intake, and taking vitamins and minerals and consuming calories. Again, you just have to think about with these dialysis patients, whereas their kidneys were instrumental in controlling the amount of fluids and electrolytes and so forth, and now they're not able to, and so we have to do some manipulation with their diet. So that there's not too much or too little and so forth. And so dietary is very important to be a part of the team rather. Now, protein restrictions early in the disease state prevents certain issues with CKD and preserve renal function. Restrictions depend on the degree of renal and waste elimination impairment. The more impairment, the more difficult it would be to excrete those the waste products or the metabolites, if you will. When they have a CKD, depending on the severity of it and all, remember they have a decreased GFR rate, and severity of signs and symptoms can be pretty significant, again, depending on the amount of failure with them. All right. Now, by reducing protein intake, people with kidney disease who are not on dialysis can reduce stress on their kidneys and prevent the buildup of urea in the bloodstream. Because this is what happens when we consume proteins. It places a lot of stress on the kidneys. And of course, as far as a byproduct of protein metabolism, you have this urea that can build up. It typically doesn't build up as long as the kidneys are working well, but When these patients are not on dialysis and their kidneys cannot do the job for them, then there's that chance of this urea building up, causing more toxins to be produced in the blood stream. Now, the body produces urea, which is a compound during the digestion of protein. So when we digest proteins, one of the byproducts, again, is urea. And of course, the kidneys would normally eliminate, this toxic buildup. All right. And also take a look in your book. Your book should continue the discussion of how to prevent infection in these patients, preventing injury, minimizing fatigue, anxiety, and also recognizing and managing depression as well. And so all that should be a part of your reading. So let's make sure we get the reading in. Now, this is a very important slide that we are getting ready to delve into. So just really listen up. I'll try to place emphasis on certain things that I really feel you need to know. And much of this information is just so important because you will see a lot of these patients come in with kidney disorders, and that requires replacement of some sort. So kidney replacement therapies, we're talking about hemodialysis. And so with hemodialysis, we're talking about dialysis settings to think about, the procedure itself, anticoagulation, which is a part of the therapy, their vascular access, nursing care, and also post-dialysis care. Now, even though you have specialized nurses who actually do the dialysis, dialysis nurses typically in the clinics, and of course they're the ones who would do the 3 or 4 hour a day treatment 3 times a week, and so that would be more of that responsibility. However, let's say, for example, if your patient is in the ICU and you're the ICU nurse, then you would be the one who are managing the CRRT, which is another form of dialysis, but it works over a 24-hour period of time instead. Now, kidney replacement therapy, or KRT, requires a stage 4 and 5, or is required during stage 4 and 5, because the toxins that are now starting to build up at that point are life-threatening. And so after we have tried a diet with these patients, drugs, drug therapy, fluid restrictions, once these combination modalities have become ineffective, then you have to resort to KRT. Now, hemodialysis is the most common KRT that is employed. So what does hemodialysis do? All right, one might ask, you might ask, you should ask. So this device removes excess fluids, waste products, and it restores fluid and electrolyte balance. Remember, this is all what the kidneys would normally do. But now scientists have developed this device that does these things for these patients because their body cannot. It involves passing the patient's blood through an artificial semi-permeable membrane to do the job kidneys normally perform, such as filtering, excretion functions. That's what the kidneys do. The kidneys filter, they excrete, they have excretory function. Now, complications from hemodialysis, in other words, hemolysis, in other words, breaking down of red blood cells, hemolysis, air embolism, dialysate error. Remember, dialysate is that fluid that is used to help manage the electrolytes and fluids and so forth. Contamination, and yes, sometimes the dialysate or just the procedure itself, if you're not using aseptic technique, can cause contamination and, of course, sepsis in these patients. And also exsanguination is another complication to consider. And this is basically when the dialysis catheter that's inserted in the patient's body, if it's not managed properly, they can bleed out. That's exsanguination. Now, hemodialysis is indicated for certain patients. You will initiate it if someone's pH is less than 7.2 and they don't respond to treatment. And as I talk about this, I would be remiss in not informing you or reminding you that the kidneys do handle one of its great functions is acids and bases. And so, if the kidneys are severely impaired and someone is becoming acidotic and the kidneys cannot excrete the excess hydrogen ions, then the patient becomes acidotic. And so, when the kidneys lose that function, then their pH becomes less than 7.2, they're acidotic. This is very dangerous. All right. And no matter how much you try to treat it, if that number does not move back between that 7.35 and 7.45, you got a problem. Houston, you have a problem. It is also indicated for patients who have fluid overload, who do not respond to diuretics, like fluid overload with pulmonary edema, or someone who develops pericarditis. Also, it is given in those patients who have symptomatic potassium hyperkalemia with EKG changes. All right. And they're given to those patients who have a condition called calciphylaxis. And this is thrombosis and skin necrosis that is seen in stage 5 CKD patients. It is also given to those patients who ingest toxins such as dialyzable drug overdose or poisoning. So patients who are who consume a poison sometimes require dialysis. When we talk about dialyzable drugs, there are certain drugs that when patients have dialysis, you can dialyze a drug out of the patient's body. Those are dialyzable drugs. Sometimes, we have to know if a patient is on, or who, let's say, for example, if the patient's in a hospital and they're getting ready to go do dialysis, you have to look at their medication list to see if you want to hold the medications until after dialysis, and which is the most likely case, because otherwise, if you give them certain medications, all that's going to happen is when they go to dialysis, it's going to dialyze it back out, and so it'll be as if they've never gotten the medication. There's a list that should be in your readings that should tell you what drugs are dialyzable, and so in your doctor's orders, it will likely say what to hold, or the dialysis nurse will give the drug themselves, and so they can kind of time it. So as they dialyze the patient, then they can go ahead and after finishing up and what have you, go ahead and give the patient the medication at that point. And so there are certain things that the dialysis nurse will do, even giving blood. They'll do things like that. But look at your orders, of course. Now, sometimes hemodialysis is started when uremic symptoms are present. And so what is uremic symptoms? Remember, the uremic is the poison that is building up in the patient's blood that the kidneys are supposed to get rid of. All right. And when the toxins build up, then the patients develop symptoms, and those uremic symptoms are intractable nausea and vomiting, confusion, seizures, or severe bleeding from platelet dysfunctions. Because remember, with this toxins building up, even the platelets won't work very well. They become dysfunctional, causing bleeding. And of course, whenever you read about intractable pain, intractable nausea, vomiting, and so forth, intractable just means it's hard to deal with or control. So no matter how much pain medication you give, this patient has intractable pain. All right. Now, length of time on hemodialysis depends on the patient's age, the cause of CKD, whether or not there are comorbidities such as cardiovascular disease or diabetes. The criteria for hemodialysis is irreversible renal failure with ineffective other treatments, no conditions that would seriously complicate hemodialysis. There's also it also depends on, as far as the criteria for hemodialysis, patient preferences, their values, what does the patient want, and expected ability to continue or resume roles at home or work or school. These are some of the criteria that we look at. As far as dialysis settings, hemodialysis can be done in the hospitals, community setting, home. Now the latter two, it can be done in the community setting or home, as long as there are no complications. All right, and it can be managed safely. Now, as far as the procedure is concerned, now hemodialysis works by a process of diffusion. All right. That is molecules moving from an area of higher concentration to lower concentration. Now, larger molecules cannot pass through the actual membrane. All right. Now, dialysate is the dialyzing solution, which contains a mixture of electrolytes and water, and it basically resembles the human plasma. Now, the patient's blood consists of nitrogen, waste products, excessive water, and excessive electrolytes. This is the abnormal that occurs with renal failure. And this is what we're trying to work on and what we're going to fix with the dialysis. Now, during dialysis, hemodialysis, waste products move from the patient's blood into the dialysate due to their difference in concentration or diffusion. All right. Now, water is removed is moved from blood by a process called osmosis. Now, electrolytes move in either direction. Volume is removed from plasma by applying positive and negative pressure in the system, the hemodialysis system itself. So kind of just going through the procedure with you, or just giving you an idea of the complex process. Now, the hemodialysis system consists of a dialyzer. A dialyzer is an artificial filter containing fine fibers. Now, the fibers are hollow with microscopic pores in the wall, also known as semi-permeable dialysis membrane. Now, dialysate, the vascular access routes, and as well as the hemodialysis machine. All right. Now, dialysate is made from water, chemicals, and it is free of waste products or drugs. The hemodialysis system has a built-in safety feature in it as well. Now, so I don't want you to get too crazy about this whole process. It's not like we're going to give you a test and you have to go through this whole, step by step, is doing this and doing that. But just kind of remember those big concepts that I mentioned about the dialysis and the diffusion process, osmosis, as it relates to the water, and how it involves the dialysis, the fluid and electrolytes, and the and all these things. So don't get overly crazy about that. As far as anticoagulation is concerned, since blood clotting can occur, because remember, these patients' blood is leaving their bodies, going into this machine, and before it returns back to their body. So there is always that chance of coagulation, and so we have to institute anticoagulation. And so since we know that this can happen, heparin is used to prevent this. All right. There is a reversing agent or antidote for heparin, and that is something you should never, ever forget, and that is protamine. All right, protamine. Now, heparin is active in the body for 4 to 6 hours after hemodialysis. All right, it's quite active. So what that means is if heparin is going to be active for that period of time, then we have to observe these patients for hemorrhaging during and after hemodialysis. So we're always watching for bleeding in these patients. This also means that no invasive procedures during this time, post this procedure. All right, so Foley catheters, IVs, NG tubes, anything invasive, no go. All right, now, as far as the hemodialysis access, a vascular device, could be an AV fistula, graft, or what have you. This device requires the availability of high flow blood for a period of 3 to 4 hours of hemodialysis. All right. So this is how durable this device has to be. It has to be able to handle high flow blood for about 3 or 4 hours while this patient is receiving hemodialysis. All right. Now, in order to do that, we have 2 devices that we will discuss in particular, 2 long-term devices. One is called an AV fistula. Now, that is the one that is even much more durable and tough, right? And then you have the AV graft, which we'll talk about as well. Now, the AV fistula is surgically connects an artery of the patient to their vein, right? Now, the vessels that are mostly used for this procedure are the radial or brachial and a cephalic vein of the non-dominant arm, all right? Now, after the AV fistula is created, all right, once it is created, surgically created, time is needed for it to heal and mature. You can't use this device right away. Now, as the AV fistula matures, increased pressure of arterial blood flow into the veins causes vessel walls to thicken. All that high flow blood that just keeps being pushed through this device and the vein and so forth, it becomes more thicker because of all that increasing pressure of blood flow coming from the arterial side. This thickening leads to increased strength and durability because when this patient has hemodialysis, there's going to be continuous cannulation of the AV fistula. All right, there's like a needle that will continue to be used to access that hemodialysis device, and so. As I mentioned, with the high arterial blood flow into the vein, it causes the blood vessel walls to become thicker and more durable and stronger. All right, so that it can take repeated cannulations, and hopefully the patient will have this device for a very long time. Excuse me, folks. All right. We got to get through this, right? Now, some fistulas can take up to 4 months before they can be utilized. And for this reason, a temporary AV shunt or hemodialysis catheter is going to be used. We call it a perm cath sometimes. So, but yeah, so we will use that until the more permanent device is healthy and ready for use. Now, one needle is inserted in the venous end, and the other is going to be inserted through the arterial end for hemodialysis when the device is actually especially working, and when it has matured, healed, if you will. Now, an AV graft is used. Now, remember that there's a difference. You have your AV fistula, which is the more durable version, but then you have the AV graft, which is see, with the AV fistula, you're connecting the artery and the vein. Of course, with the AV graft, this is more for those patients who don't have good vasculature system, and so you have these tubes that connect the veins and arteries with the AV graft. You mostly find those inserted in your older population who don't have the best veins. So anyway, an AV graft is used when an AV fistula does not develop. You know, that if the surgery that has been performed doesn't pan out, if the AV fistula doesn't develop or mature, or they're used when for complications, when complications limits its use. Again, usually mainly for the older population. Now, an AV fistula is a direct connection between the patient's artery and one of their nearby veins. It's an artery and vein, AV fistula. An AV graft, sometimes called a bridge graft, is an indirect connection between the artery and vein. Most commonly, a plastic tube is used, but donated cadaver arteries or veins can also be used in this respect. Now, as far as precautions is concerned, we want to assess for circulation in the fistula or graft, and this should be done in the lower portion of the arm. So let's say if someone has a AV fistula in the maybe the right forearm, right? Then you always want to check for circulation distal to that graft insertion site. And we check distal pulses. We check for capillary refill in the affected arm. Also, we check for a bruit and a thrill. A bruit is done by the bell up your, the bell up your stethoscope, where you place it over the AV fistula, and you'll hear a kind of a whoosh, whoosh, whoosh kind of sound, right? And of course, the thrill is when you take the palm of your hand and you place it over the AV fistula. It almost feels like some electricity is going through. That kind of thrill is something we palpate. So one we auscultate and one we palpate. The thrill is what you palpate, right? Maybe make a little rhyme out of it. I don't know. Do with it whatever's easy for you. All right. Now, make sure in your readings you read the sections on how to properly care for patients with AV fistulas and grafts. For example, no blood pressures, no venipunctures in the arm that has the AV fistula or graft. All right, and so you should have some information in your book that speaks to that. Let's see. Now, as far as complications from hemodialysis, This includes thrombosis or stenosis, because remember we are dealing with a vascular, the vascular system. There can also be infection, which is why aseptic technique is so vital here. Aneurysm formation can occur, a weakness in the vascular wall itself. Ischemia or heart failure can occur as well. Now, your book should also talk about some of the interventions that are employed in order to prevent problems with hemodialysis. For example, to prevent clotting, we want to avoid constrictive devices such as blood pressure cuffs and tourniquets, even clothing, if you think about that. Now, the most common complication is thrombosis or clotting of the AV access device. And most grafts fail due to high pressure arterial flow entering into the venous system. That venous system can only take so much pressure. Remember, the arterial system is the strongest, most powerful system. But when that blood flow is entering into the venous system, it can cause these high flow problems. If a clot does develop, TPA is the major drug that is used to break up the blood clots. That will sometimes be employed. Staphylococcus is the most common organism found to cause infection in these patients. And so ensure before and after each cannulation that we're using antimicrobial agents. There's another complication that is called a Still syndrome. And what does this mean? When ischemia occurs from the fistulas decreasing arterial blood flow to areas below the fistula, then these patients, the signs and symptoms will vary. They can go from varies from cold or numb fingers to gangrene. Other complications to watch for is hypotension, dialysis disequilibrium syndrome, cardiac events, and reactions to the dialyzer as well. Now, as far as dialysis disequilibrium syndrome, some of the signs and symptoms are nausea, vomiting, headache, fatigue, restlessness. And so if you can reduce blood flow at the onset of these symptoms, this syndrome can be prevented. So that's one of the interventions that the nurse may have to perform. Now, cardiac events occurs when patients have a cardiac history, such as left ventricular hypertrophy, pericardial disease. We want to assess for pericardial friction rub before hemodialysis. These are, again, some of the complications that can occur. Just read about the different complications in your textbook as it relates to dialysis. All right, and then you have your temporary vascular devices. Temporary catheters are placed into the subclavian well, the subclavian, the internal jugular, or femoral vein, since the lumen in these devices are smaller, more time is going to be needed to complete the hemodialysis, like 4 to 8 hours. So you know how with AV fistula, they're large enough, the lumen is large enough, and they can take such high pressure, you can be done in 3 or 4 hours. But when a temporary vascular device is, hemodialysis device is required until these devices mature and heal, then a temporary cath is placed in these different locations, but it just takes longer to perform the dialysis. As far as nursing care is concerned, now some drugs are dialyzable, and then I talked about this briefly. Some drugs are dialyzable and will be removed from the blood during hemodialysis. Therefore, some may need to be held until the hemodialysis is completed. And so your book should tell you what some of those drugs are. And they should be identified on your medication record as well. Also, contact the hemodialysis nurse to see if antihypertensive drugs need to be held, especially the ones that can cause hypotension during dialysis. So you don't want to be giving these patients that particular medication, and then while doing dialysis, drops their blood pressure even more. Right. Now, while the patient is receiving dialysis, we should be thinking about diversional techniques to distract the patient while they're having this therapy, such as reading. There's lots of health teaching that could be done during this time as well. So in other words, help the patient be as productive as possible. But I do love the health teaching during this time as well. As far as post-dialysis care, common problems after hemodialysis is low blood pressure, headache, nausea, vomiting, dizziness, and muscle cramps. And so we may have to treat supportively those patients who have these issues. We also want to compare the pre and the post dialysis weight. We're reviewing the vital signs, of course. Normal saline is normally administered if hypotension occurs. Temperature can be elevated due to the fact that the machine itself, the dialysis machine, it actually warms the blood slightly. And so we want to make sure that the temperature is real, in other words. If the patient seems to be developing maybe septicemia, then blood cultures is certainly going to be warranted at that point. But just keep in mind the dialysis warming device, it does elevate the temperature a bit. All right. Now, if heparin or citrate is used as far as blood thinners, no invasive procedures for 4 to 6 hours after dialysis should occur. We should monitor for bleeding during hemodialysis and 1 hour after hemodialysis. We always want to keep the lines, the dialysis lines patent. The nurse should prime the access device with heparin and normal saline so that we can use it for a long time if need be. Now that was indeed a mouthful surrounding KRT. All right. Now the peritoneal dialysis is not as long, um, but a siliconized rubber catheter is placed into the abdominal cavity for infusion of the dialysate. All right. And so the types of peritoneal dialysis selection depends on the patient's ability and their lifestyle. And these are just some different forms of hemodialysis that I won't belabor, but just be aware of the different types. All right. Now, peritoneal dialysis allows exchange of waste, fluid, electrolytes to occur in the peritoneal cavity. All right. Um, Peritoneal dialysis is slower than hemodialysis and requires more time to achieve the same effect of hemodialysis. And maybe that's why people choose hemodialysis over peritoneal dialysis. Now, other disadvantages of peritoneal dialysis are protein loss in the outflow of fluid. There's also potential risk for peritoneal injury, and there's discomfort from indwelling fluid going into the abdominal cavity. There can be quite a bit of discomfort in that regard. And your book should also speak to some advantages and disadvantages of peritoneal dialysis. So just take a look at that. Now, patients who are unable or cannot tolerate anticoagulation need peritoneal dialysis. Also, patients with access device issues. I mean, you can't place a AV fistula or a graft and whatnot, and so the next best therapy will be the peritoneal dialysis. Peritoneal dialysis is better for patients who need to wait until the AV fistula matures. All right. Ultimately, they will be on AV. They will have hemodialysis via the AV fistula, but it just hasn't matured yet. Peritoneal dialysis is better for elderly patients due to its flexibility. It's more flexible for these patients. All right. Now, peritoneal dialysis cannot be used if the patient has a peritoneal adhesions. Maybe they've just had so much scar tissue, maybe surgeries and such as that, or extensive intra-abdominal surgery as the surface area of the peritoneal is not sufficient for dialysis exchange. It's just too scarred up. Now, patients with repeated peritoneal infection develops fibrosis, in other words, peritonitis. This can also decrease membrane permeability. Remember, we're using the patient's membrane, peritoneal membrane, to facilitate that dialysis process. And of course, if too many infections can change that tissue to the extent that the permeability is altered significantly. Yes, see, I talked about the silicone rubber, how it's surgically placed for infusion of the dialysate. When we think about dialysis, we must think about a three-stage process called infusion or fill. All right. And this is basically when, and I'll show you a bag here shortly, or the host or the setup, if you will. But so the infusion itself is when the dialysate is leaving the bag and infusing through the patient's peritoneal cavity, all right, to fill that cavity space. Now, depending on the concentration of this dialysate, as it sits there, which is what we dwell, the fluid, the dialysate will dwell. There's a certain dwell time, maybe 30 minutes, maybe longer. But there's a certain dwell time where this fluid will remain there until it does its job of pulling and this waste from the patient's body, if you will. Once that time frame is up, then the next stage would be outflow drain. So after a period of time, the dialysate is drained into another container, and this make up one PD exchange. All right, and your book should point to some of the of the procedure itself. So just make sure you guys take a look at that. All right. Now, as far as the process itself, now peritoneal dialysis occur through diffusion and osmosis across a semi-permeable peritoneal membrane and capillaries, pretty similar to the hemodialysis, if you will. The peritoneal membrane is large, is porous, allow particles, water to move from areas of higher concentration to lower concentration in dialysis fluid. Again, that diffusion osmosis process. Now, fluid and waste products dialyzed from the patient move through the blood vessel walls and the interstitial tissues and peritoneal membrane. All right, and then and removed when all this is removed when dialyzing fluid is drained from the body. Remember that outflow that I talked about. All right. Now, factors that affect the peritoneal dialysis efficiency, things like infection can affect it, vascular disease, decreased perfusion of the peritoneum can also alter the efficiency of this system. Now, water removal depends on the concentration of dialysate. That is the tonicity, the concentration, or the number of particles per liter of fluid. An increased dialysate concentration, it makes the solution more hypertonic, right? The more concentrated it is, the more hypertonic it is, the more powerful it is in pulling off fluids and other things. Now, the more solution is hypertonic, the greater the osmotic pressure for water filtration and fluid removal during exchanges. And so you'll see with these dialysate bags, they have different percentage levels, 2%, 3%, 4%, 5%. You know, the higher the percent, the greater the tonicity or concentration, or osmolarity is also what we refer to it as. Right. Now, the types of peritoneal dialysis of the two main types, two most common are continuous ambulatory peritoneal dialysis and continuous cycling peritoneal dialysis. Right. Let's see. Now here's just an example here. This is the dialysis solution here. And of course, this is what we're going to infuse into the PD catheter. This is a PD catheter that's tunneled into the peritoneal cavity. And and here is your, of course, your peritoneum itself, this membrane, right? And when this fluid is infused into this membrane, this is what happens as far as the strength of the solution and its ability to pull off fluids and electrolytes and waste products and all sorts of things like that. And of course, you know, this is controlled by gravity. And so what we do in many cases, well, see right here, this allows the fluid to drain in fairly easily. But then we'll take the bag for the outflow and we'll place it on something, let's say maybe a container on the floor, and this will cause fluid to drain from the peritoneal cavity to get rid of that whatever waste, and it actually looks like urine, to be honest, and actually smells like urine. So that gives you an idea of that, right? All right. And you have to really use aseptic technique here, because once these patients have repeated infections, they can no longer become or be a candidate for peritoneal dialysis. And so these patients go through extensive training. Let me tell you, it is extensive. And they have to have the mental grit and cognition and hopefully family support systems and all to be able to carry out this process at home. So, but has a nice flexibility, if you will. And this is another device, the continuous ambulatory peritoneal dialysis device. See the dialysate solution up here. These bags are pretty big, by the way. So you ladies, you have to really get some strength in those arms, and some of you guys. Anyway, and of course this is your catheter, and the whole process is just amazing, to be honest with you. But this is the peritoneal catheter, and how when this dialysate solution is infused, it bathes the peritoneum and all the fluids and electrolytes and the waste and everything is drained outward. So it's a pretty interesting concept. And we won't even get into this one. This is some automated peritoneal dialysis. That was a little too complicated for me, but just take a look at it. All right. As far as complications of peritoneal dialysis, all right, we have peritonitis, pain, tunnel infections, poor dialysate flow, fibrin clot formation, dialysate leakage, and other complications. Now, complications from peritoneal dialysis can be prevented as long as there's meticulous care and appropriate patient education for self-management is performed. Peritonitis, major complications caused by connection site contamination. We must use meticulous sterile technique to prevent this from happening. As far as pain is concerned, Pain on inflow is common. You know, when the dialysate is inflowing into the patient. It's common with first-time users, peritoneal dialysis. So there is a warmer, not a microwave, but there's a warming device that comes with this whole system setup. Um, and so warming the solution before infusing it can cause more comfort for our patients. All part of the self-management teaching process. As far as tunnel infection, peritoneal dialysis catheter should be clean, um, dry, and without pain or inflammation. Dialysate leakage, pulling or twisting of the catheter can also increase risk of infection. As far as signs and symptoms of tunnel infection, um, we must look for redness, tenderness, and as well as pain, right? As far as poor dialysate flow, um, this can be often due to constipation. All right, and so enemas or bowel preps are helpful in preventing constipation. Patients should eat fiber, diet, use stool softeners, other outflow problems or other outflow problems can include kinked or clamped connection tubing. The patient's position. The patient may have to be repositioned in order to relieve, to enhance or facilitate flow of the solution. These patients can also develop a fibrin clot formation. Um, and so there are different techniques that are sometimes, for example, heparin might be given in order to help break up the clots, but they are expected to be seen in the solution as well. Um, a calf displacement. To prevent uh, this from happening, repositioning, gravity, drainage, unkinking of the tube, and good body alignment are good techniques to consider to prevent calf displacement. All right. Then there's also increased abdominal pressure from sitting or standing, or coughing contributes to leakage at the peritoneal dialysis catheter site. As far as the fibrin clot formation, this occurs after placement and also with peritonitis. And so you should milk the tubing to aid the flow and also remove the clot as well. As far as dialysate leakage, this does occur mostly with your obese patients, diabetics, older patients, patients on long-term steroidal use. May take 1 to 2 weeks before they can actually tolerate a full 2-liter exchange. So you have to sometimes limit the amount of exchange or dialysate that they're receiving before they can actually really tolerate it. Other complications, some bleeding expected after tube placement. It does clear within a week or two. Other issues can be bowel perforation as well. So watch for that brownish looking drainage that looks almost stool in color. Now the effluent, which is the solution in the dialysate, which is the dialysate fluid, we refer to it as effluent, should be clear, should be light yellow. So when you hold the bag up against light, it should be clear and light yellow. If the outflow is brown, um, think about bowel perforation. Um, if the outflow is the same color um, as urine with the same glucose level, bladder perforation may be a possibility. And if the outflow is cloudy, opaque, think infection, maybe peritonitis. Now, before treatment, we want to evaluate the baseline vital signs, apical, radial pulse, temperature, respiratory rate, breath sounds, weight, laboratory tests. Get your baseline. Continually monitor the patient for respiratory distress, pain, and discomfort. We want to make sure we monitor the prescribed dwell time. There are orders that will tell you how long the solution should dwell in the peritoneal cavity. And then I'll also initiate outflow as ordered. Observe outflow amount and the pattern of fluid. You don't want to infuse, let's say, 4 liters and maybe only a liter comes out. There could be an obstruction or outflow obstruction problem. You get some pretty extensive training on this procedure because sometimes we have to do this in the hospital for patients as well. Always weigh patients, same scale before the procedure, at least 24 hours while receiving peritoneal dialysis. Remember, if the outflow is less than the inflow, the difference retained during dialysis is during dialysis and counted as intake. So we'll count that as intake. If the outflow is less than the inflow, the difference retained during dialysis, and we count that as the intake. So. Um, and actually, the next piece of information here, I already have a voiceover on the kidney transplantation, and I don't know if you actually need it for this class, but I will check. But I do have the presentation, and I can always upload that along with this one here. So I think that should be it. I think I'll go ahead and post it anyway because you guys should know something about this kidney transplantation. And folks, that is about it. We made it, and I'm so happy that I got through the end, and it didn't take as long as I thought. But it is a lot packed with a lot of information, as you can see. So you guys should be almost experts on CKD and hemodialysis, peritoneal dialysis, and so forth. And anyway, I hope you all enjoy the presentation, and I hope it's clear enough for you that you feel more comfortable with the information. And we will talk later. And I thank you very much. Bye for now.